Hello there. If you are joining us, it is not quite 6 o'clock on the East Coast. For people like me, 3 o'clock on the West Coast. We've opened it up about a minute early so that because we have so many people who have registered for this event. We always like to start about a minute beforehand so we can get everybody into the room and start promptly at the hour. So just bear with us for a moment. So we probably will just give it another 30 seconds. If you're just joining us, please hang on just for a moment. We always open up the webinar about a minute early so that people who are in the waiting room can get in and we can always start promptly on the hour. Okay, we are now live. Hi everyone, my name is Sam Guild. I'm the president of Melanoma. Welcome. We are joined this evening with two very distinguished melanoma experts, Dr. Jeff Farma and Dr. Anthony Olszanski from the Fox Chase Cancer Center. Welcome, gentlemen.
Hi, how are you?
Hi. So for our audience, as you know, this evening, we're going to be delving into the future of melanoma and what to anticipate in 2022. I have a gist of what's going on, and I can tell you there's a lot there. So I'm really excited that we have the opportunity to share that with you. But just a couple of quick logistical matters before we get started. If you are joining us via Zoom, please use the Q&A for your questions. That is the easiest way for our two guests to get those. If you're joining us via Facebook, you also have the opportunity to ask questions by putting them into the comments section. And then one last thing, I want to mention that we are recording the event. So if you want to watch the event again or share it with others, you will have the opportunity to do that. And now, without any further delay, I say we get started. Let's go.
Great. Thanks, Sam. We're happy to be here. I'm Jeff Farma. I'm the surgical director of our melanoma and cutaneous program at Fox Chase. And I have the pleasure of working on a daily basis with Dr. Anthony Olszanski, who is a medical oncologist and the medical director of our melanoma and skin cancer program at Fox Chase, and also a member of the NCCN panel for melanoma and really an expert in the systemic treatment of patients with advanced melanoma. So we're really happy to be here, and thank you for the invitation. I'll kind of start with some questions, and we hope that this will be a good banter between the two of us. We work together all the time and are good friends, and we really are both exceedingly passionate about taking care of patients with melanoma. We talk about every one of our melanoma tumor boards, how excited we are in the changes that we have seen in what some would consider a short period of time, in how much new agents we have and opportunities to treat patients with melanoma, and how the landscape has changed so dramatically in such a short time period. And that's what gives us so much passion and excitement when we see patients and ways that we can come up with novel therapies to treat patients with melanoma. I think we'll be talking about a lot of really interesting things, but I think number one that all of you should just take home is, one, we're still not doing great with screening. So we can talk about all the new immunotherapies or injectables or drugs or anything, but really it still comes down to we have to improve screening. Patients need to see dermatologists. If you have a friend or family member or personally a lesion or mole that is changing or dark or raised or wider or bleeding or anything, you need to get it checked out, because we can talk about all these fancy, expensive, really like amazing things we're doing. But our hope is we don't have to use any of these. We want to just find things early. And so I personally, as a surgeon, see lesions that are, precancerous, early to advanced disease. And really, I can't stress enough how important screening is. Tony, any specific comments before we kind of get into some discussions?
No, thanks, Jeff. Thanks for the introduction as well. I really am passionate about this melanoma, as Jeff has already said, and we really are. In fact, we run a multidisciplinary tumor board, and we're obligated to try to teach the medical students and the fellows. And it's actually quite hard to keep them all updated on all the advances because they're happening so fast. so incredibly quickly. So it's been really, really fun for us to try to keep up to date with all the data and be able to not only present that to our peers, but also obviously our patients who matter the most. And to tack on to what Jeff has already said about the screening, I totally agree. We need to get people back into dermatology because that's where we can discover things and get them off early before they really cause problems. I will also add that we're still not doing very well with UV exposure. And one of the things we really want to hammer home, of course, is keep your skin covered, right? It doesn't really matter what the color of your skin is. You're always at risk. And so less sun exposure is good. Tanning beds are bad. That's sort of the message that we should be getting across to everybody. I typically see patients after they've had melanoma. We still talk to them about avoiding the sun, but most of the time I spend my time in my education with them, telling them to please educate their families, keep their children, keep their grandchildren safe, because ultimately most melanoma is really a preventable disease. If you can put Jeff and I out of a job, we'll be quite happy. But it's going to take some time before that happens.
So there was a question that, and we'll intermittently answer some of these questions or chat comments, but someone asked about how frequently someone should be screened and how often survivors should go. And so there's definitely differences in the literature. I think someone that has no history of skin cancer, likely for basic screening, it's not unreasonable to see a dermatologist every 2 years or every year or two. If there's any concerning spots or moles or anything, then that could change. If you have a diagnosis of a skin cancer, then generally you should, or melanoma should be seen by a dermatologist, generally 2 to 3 times a year, at least for the first couple of years. If there's multiple biopsies that are being done or atypical nevi that are being identified, then you should stay with that surveillance strategy. If with time, none of the moles are changing and you feel and the dermatologist is confident, then maybe going to twice annual screening is not unreasonable. So let's get into some kind of controversial topics. And, I can talk about some of the surgical management, but let's talk about lymphadenectomy. Has things changed at all, Tony, on kind of how we look at patients? So a patient comes in with a positive sentinel node, and I see a lot of patients and do a lot of sentinel nodes, and they come in and now they have a positive sentinel node. What are your thoughts on I kind of think of this as there's 2 main discussions in this setting, but what are your thoughts as a medical oncologist on lymphadenectomy and who should have it or who shouldn't have it at all?
Yeah, thanks, Jeff. I think that we do have a lot of scientific data to help guide us a little bit in this avenue. And that scientific data is coming both from the surgical sector, when we talk about trials like the trial called the MSLT2 trial, and when we also talk about the medical sector, when we talk about trials that looked at the use of adjuvant therapy or the use of therapy after surgery for patients with stage 3 melanoma. And we really have a lot of data now to sort of help guide us. Clearly, there seems to be 2 camps that we need to consider. Those patients who, when you're doing surgery and you do your primary wide excision and put in the dye to try to see if we can track where the lymph nodes might be, we take out that sentinel lymph node, the lymph node where the cancer is most likely to travel if it goes someplace. And if that is positive, traditionally, we used to do complete lymph node dissections, going in there and taking out a lot of tissue. But now we have results again from some trials that suggest that maybe that's not always necessary. We have good data now supporting the use of immunotherapy and good data to suggest that we can do surveillance on that lymph node basin where that sentinel lymph node was taken out using ultrasound techniques, for example, to make sure that we don't see any recurrent disease. And Jeff, I know that at least in the melanoma tumor board, that's something we talk about a lot, is these patients with these sentinel lymph nodes that have relatively low disease in them, and we can do a surveillance while giving them adjuvant therapy and perhaps precluding them and avoiding further surgery. And yet we have the other camp where, they're presenting with recurrent disease, or they might have larger lymph nodes that we can feel on an exam or see on a CT scan. That's probably a different ballpark where we really do need to consider a bigger surgical resection.
Yeah, I totally agree with you. And, I definitely think education is key. I don't think any of those trials are black and white where it's 100% this way or that way, but you have to have a discussion and talk to your provider and really decide what's best for you. Some patients cannot come in and be seen for close surveillance, and those patients probably are better served with having a lymphadenectomy. Or if there's a lot of concerns in the lymph nodes, we still do lymphadenectomies. Or if you have a contraindication to potentially having screening or other therapies, we will consider a lymphadenectomy. And so I still think, I think it's very important that you have a discussion. There's risks of anything we do and risks of lymphadenectomy. And we get concerned about lymphedema, although honestly, we don't see really, really bad lymphedema like we used to. And especially the combination of lymphadenectomy and radiation tends to be more concerning. So these same patients, one discussion, a positive node, is what we do with the lymph node basin from a surgical standpoint. But then can you talk, Tony, a little bit about, well, what should we do from a systemic standpoint? So tell us a little bit about current adjuvant therapy and kind of what's on the horizon.
Sure. So we have really two groups of patients that we need to consider anytime we have a diagnosis of melanoma, because we know that about 40% of patients have a change in the DNA protein format called BRAF. So it's a gene, a DNA gene that eventually becomes a protein, and that's called BRAF. And if
sorry to interrupt. So who should we check that on even?
So we literally check it on every patient, at least with stage 3 and above. So nearly every patient gets that BRAF gene detected. And why stage 3 and above? Well, that's where the FDA approval is for using these types of targeted medications. And so we do try to check everybody in those two groups.
And so patients only get BRAF testing, or should we do wider? And are there other patients that we should consider testing on?
Yeah, rarely we actually do see other mutations that can be targeted. One of them is called KIT, and another one is called NRAS. We have some of those medications that we can use or deploy. And really, we got a lot more from the sequence testing that we're doing now. We apply a large panel to the tumor to try to understand the underlying genetics. And from that, we can get a number called the tumor mutation burden, which tells us a little bit more how likely immunotherapy might be work. But at the end of the day, we apply either immunotherapy or targeted therapy to these patients. And for the most part, my practice, of course, in Fox Chase is applying immunotherapy to most of these patients, but there's really good data also to support targeted agents for those patients with a BRAF change. So I really do think that we have some great options there. And the way that we apply this, the way that we talk about toxicity is different. And that's what goes into these conversations. Immunotherapy and targeted therapy are different.
Yeah, and so we test anyone with stage 3. If it's a recurrence, so someone who had an earlier stage melanoma now presents to us with a recurrence, we will do profiling on those patients or in the metastatic setting, because I think it gives us more information about the tumor, not only for active treatment, but potentially future treatments. So it's important that patients are getting that and that's being discussed with them. Let's kind of shift gears a little bit, Tony. There are some questions, but I think let's talk about a little bit about systemic therapy. So there's a lot of great things. We always talk about that we have patients that we can't even believe what we're seeing on their scans. And so can you talk about what we're giving them?
Are you referring to?
I think let's talk about standard systemic therapies and kind of in the metastatic setting. And then I think we can shift gears to kind of some novel neoadjuvant strategies.
Yeah, we have some really interesting new data that's coming out, and we will get to that. Right now, with patients with a large amount of disease, what we would call metastatic disease, doesn't even have to be a large amount, but outside of the area where it originally occurred, we're using therapies, either targeted therapies or immunotherapy. But in the immunotherapy sector, we're often using 2 immunotherapies together. It's in those patients where we see the best response. But as we saw in the chat, there are some patients who can also have fairly significant side effects. And we have to try to manage those side effects because they can be challenging and it can be difficult to reintroduce immunotherapy to those patients because we don't want to cause the same side effects over and over again. with that said, we're doing a lot of research right now to try to figure out if there's other agents that we can use that will minimize the side effect risk if we go ahead and re-challenge patients with immunotherapy. So we're really making some grounds on that as well. We typically would apply steroids to patients to try to calm down the immune system, but now we're really using more, if I can use the word targeted again, targeted approaches to try to suppress the immune system in very specific ways so that we can reintroduce immunotherapy. And we do have, again, targeted therapy. We have medications that will typically go after what we call these BRAF mutations, and that can also be applied. And I'm going to talk a little bit about a trial where we got top-line results now about whether or not immunotherapy is best to be given first or targeted therapy is best to be given first. So really a lot of new advances in melanoma and a lot of new advances coming up.
Great. So why don't we talk about one case so there's some patients that come in and we see them and we are concerned on the initial presentation that we see the patient and just at their initial, either their scans or their imaging, that we know that this is a very concerning melanoma. So I'm going to share a couple slides I have. Can you see that?
We can.
Yeah. So this is just a brief case and we can kind of talk through it. I think we both have treated this patient. So this was a 60-year-old woman and she was referred in and really we didn't have a diagnosis. I actually had to do a biopsy of this lesion because the outside providers, it was inconclusive and they didn't know exactly what it was. And for all of you that, if you're not squeamish, but this was the lesion here. We usually talk about melanoma in millimeters. As you can see on this photo, there was a very large lesion here, centimeters in diameter and centimeters in depth coming out of the skin. Not necessarily typical of your melanoma, but we were concerned about that. When you see someone like this, Tony, what are your initial thoughts?
Well, the first initial thought that I have is, how long has this been there? Why did it get this long? What is the patient sort of going through right now? Were there barriers to healthcare? I think that that's actually one of the very first things I start talking about because it's not really normal to have stuff growing out of your skin and not take notice, right? So we grapple a little bit with that and we talk to patients because sometimes people are just afraid. They don't know what's out there. They don't know whether or not they can be treated effectively. And they don't like the word cancer. None of us likes the word cancer. And I think that fear keeps some people away from the physician. From a medical standpoint, the things that I'm very interested in now are how advanced is this disease? Is it anywhere else? We see it obviously on the skin. We want to prove the diagnosis with a biopsy. In this picture, it looks like that's been done. That's why there's that little central area that has a little divot there because a biopsy was done and this was proven to be melanoma. So the biopsy is first and foremost. That biopsy sample will be sent away for that gene testing that we had talked about. And then we're really going to want to find out from the patient, what is their past medical history? Do they have any other risk factors? What does their sun exposure look like? You can see this skin is very light. She's got a light complexion. She's got a lot of freckles on her skin. My guess is that there's been a lot of sun exposure in this individual's history. So we need to talk about that again, too, because it's going right back to, surveillance and screening and stuff like that. And
right.
So we want to make a point about that.
And so I was equally concerned, and I'm looking for in-transit nodules on physical exam. Are there other lesions on the extremity? We want to make sure we don't feel for lymph nodes. And unfortunately, I did feel an axillary lymph node under the armpit. And we really want to discern if there's any systemic concerns for metastasis. So any neurologic symptoms, anything else. And there was none of those things. But however, because we biopsied the lymph node and we ended up getting a PET scan, which is this lesion. And thankfully, there was no evidence of spread elsewhere, but there was a very, very large lesion on the arm, and then there was a positive lymph node. And so one thing, as Dr. Olszanski said, we have some trials, and we sent her testing for molecular profiling. And she did have a BRAF mutation, and this is the reports that we get if some of you have not seen these, but it tells us what mutation they have. There's different alterations genetically of the mutation, and it will give us the characteristics of that. And it will give us the information on what drugs that we could use to treat. These are BRAF inhibitors or MEK inhibitors. She also had some other mutations that are of potential clinical significance, so not what we routinely would use to treat melanoma, but sometimes we will see some other novel mutations that we have other agents that we could target in the advanced setting. And that's why this genetic testing is so important. So Tony, so what was our thought in kind of our next steps?
Yeah, so this report was really helpful too, because as you mentioned, she had a BRAF mutation, and we can see this in about 40% of patients. And so we knew immediately that we could apply a targeted approach, but we also knew that there was some new data, some of it which we were actually part of, looking at neoadjuvant therapy, or therapy applied before surgery. And so after a long discussion at the tumor board, Jeff, I can remember this really quite clearly. We were grappling with what is the best way to treat this patient. Should we give her neoadjuvant therapy, or should we move directly to surgery? And it was really because she had a relatively large tumor burden in that arm and in that axillary area that we thought that maybe giving her a couple doses of therapy before surgery would be the right thing to do. And I think that's what we actually did. We ended up giving her immunotherapy.
Yeah. And, when just seeing her, I know that I consider myself an excellent surgeon, but I also know my limitations. And I was concerned that potentially me just going in and doing an axillary lymph node dissection and resecting the lesion up front, likely, and we don't know 100%, but may have not been the best option. And so we were both amazed. And again, going back to our passion and why we love the changes that we're seeing. So we ended up treating, and this was 2 photos of that big lesion. You can see it here again. That was coming out of the skin. And we gave 2 doses of immunotherapy, dual agent immunotherapy, PD-1 inhibitor and anti-CTLA-4 antibodies. And you can see we started to initially see changes right after the first dose. And then after the second cycle, it was almost completely flat with the skin, as you can see in this image here. Tony, so you were seeing her as she was getting this done. What were you thinking?
Yeah, so I congratulated her after cycle 1. I saw her. It was 3 weeks later. She was tolerating therapy really well. I said, let me take a look at the lesion. Have you noticed anything different? And she said, maybe I've noticed something. And she picked up her arm sleeve there, and I looked at it, and I immediately put my hand on her shoulder and I said, congratulations, you're responding really, really well. That made the room sort of light up. We were really excited, and we were really happy to keep on moving forward. Gave her dose number 2. And then, Jeff, it was really important that we did consider surgery after this. And so I then immediately sent her back to you after we got through cycle 2. So this entire process was only 6 weeks. We gave her 6 weeks of therapy, and then she comes back to you. So what did you end up doing?
Yeah, so we still stuck with the plan for standard resection. And I did do, so the recommendations currently are when you have a palpable lymph node in a lymph node basin, like the neck or the armpit or the groin, to do a formal lymph node dissection. And we did that. And the pathology report was amazing. There's no HIPAA-related data on here, but I removed 38 lymph nodes in the armpit. The largest one was 2.3 centimeters in size, that big one we saw on the PET scan, that we biopsied, and it showed melanoma, and the lesion on the skin. And to our amazements, and I joke around that Dr. Olszanski is going to put me out of business, there was no remaining melanoma after 6 weeks of immunotherapy pretreatment. So the 6 weeks had killed everything. There was no viable tumor in what I'd removed, which is awesome. So amazing. And so what is she, and what now? So, and any role for any additional therapy?
So that's a great question because we actually don't know what the right answer is there, but we are giving her further immunotherapy now that she's completed surgery. She's tolerating that well. And I think that what we're going to grapple with is how long do we give it? We often give it for up to 2 years in patients with metastatic disease, but only a year after surgery. I think that's what we'll stick to, and I expect that she'll do really well.
So before we get into your slides, why don't we, I'll ask you a couple of these questions. A lot of them are chemotherapy focused. So a patient with stage 3 cancer diagnosed in July of 2019 with a lesion in the calf that had gone to the groin, inguinal lymph nodes. They underwent resection, a lymph node dissection, and then took Taflinar and Mekinist for 2 years. They recently had a recurrence with tumor in the groin, and it was just removed. Is there any recommendations for additional treatment after that? So a local recurrence in the lymph node basin, I suspect no metastatic disease now. Any role for any adjuvant therapy after re-resection of a recurrence?
Yeah, so Jeff, one of the things that we do follow, and everybody should know, is we work with and follow the National Cancer Comprehensive Center Network, the NCCN guidelines. And the guidelines are pretty clear about this, that if we do have recurrence, that we should consider further therapy after surgery. And in this particular patient, who sounds like they didn't get immunotherapy, immunotherapy would be a reasonable thing to apply in this situation. One could actually consider giving back the BRAF targeted medication as this patient had been on, because it's been such a long time since their initial application of that therapy. But generally speaking, I would say that we have another option to consider, and that's immunotherapy.
There's another question. Is melanoma only in fair-skinned or white or Caucasians, or are we seeing, or is there higher, or is there also in other patients that we see with a higher mortality? There are, and I can answer some of this. We do see melanoma in all races, classes, age groups, everywhere. It is more common in the Caucasian population. However, as was alluded to in this question, Hispanics, African Americans, Africans, all can get melanoma. And unfortunately, because it's not expected, they tend to present in later stage, which leads to worse prognosis. And also, especially in African Americans, you can get acral lentiginous melanoma in the palms and on the hands of the feet, or the hands and feet. And those melanomas historically have been more aggressive. So we've treated a lot of patients with acral lentiginous melanoma. Tony, do they have any specific molecular profiling, or when you see these patients, how do you think of that presentation?
Yeah, so these more unusual presentations, but as Jeff said, that can happen in any person. We do molecular profiling, and we're more likely to see other mutations. We talked a lot about BRAF, but c-KIT mutations, especially on acral lentiginous melanomas, are relatively common. We can see that up to 20% of the time. And we actually do have some therapies, not FDA approved, but therapies that have been recommended, like imatinib, which can really help those patients. These are difficult, though, and they often require a pretty significant surgery as well, Jeff.
Yeah, it's really difficult on the extremities. So a lot of times that may require so we do see subungual melanomas that tend to be more aggressive underneath the nail beds that require amputations of the digits. Heel melanomas are really difficult because obviously a lot of times you need a reconstruction and you can't walk on it for a while. And so these are can be very difficult to manage. I think it comes down to education. And again, finding things early and being seen is kind of the most important thing with any of these things. Along those lines of the KIT mutation, someone had asked previously, can you talk a little bit, what is mucosal melanoma? And what is the difference from mucosal melanoma versus cutaneous, both in how the presentation, aggressiveness, and how we treat it?
Yeah, that's a great question. And I saw somebody actually said, is there such a thing as melanoma occurring that you can't see? And unfortunately, there's many melanomas that we don't necessarily see. There is a form of skin melanoma where the skin lesion, the actual incidental skin lesion that occurred, probably resolved, and the patient may not have ever been aware of it. So we talk to patients sometimes if we find them having stage 3 or stage 4 disease, and we say, did you ever have a dark mole someplace? And oftentimes we'll get an answer. In fact, I did have a mole and it disappeared some years ago. And we believe that mole probably was the incident mole that was causing the cancer in the first place. But we also have other melanomas. There's 2 other classes, if you will, one called ocular melanoma that occurs in the eye. That's a pretty rare form of melanoma. We have a few drugs that we can apply in that setting as well. We try to catch those early because patients will often have visual changes, and eye exams are a little bit more common anyway, so we catch those patients sometimes. But that can be a very challenging disease to treat, and that's not necessarily related to the sun. And then we also have something called mucosal melanoma, as we've talked about a little bit. And that's melanoma that's occurring oftentimes in the mucous membranes. I've seen it a lot in the nasopharyngeal area, in the nose, in the mouth, and in the genitalia as well. And that melanoma often has a slightly different presentation. Those patients, because the melanoma is so unusual, often again present later. And they might have more advanced disease when they finally come to us. We have to be very aggressive in trying to figure out what it is, obviously, and then treating them as quickly as possible.
Great. Why don't you, let's see, there was a couple of other quick questions. Is testing done on the growth or gene testing? I think, I'm not exactly sure what that means, but I think one thing is, do you test the primary melanoma or a lymph node or metastatic site when we do genetic profiling? And honestly, the answer is we do all 3. Sometimes it depends on which tissue is easiest to get or the presentation of the patient. So if a primary skin melanoma was removed at the dermatologist, and particularly we can't get the slides or there's not enough tissue, then it may be that we sample the lymph node that recurred, or if there's a metastatic site in the liver or skin, then we'll do a biopsy and do testing on that. But you can do genetic testing or profiling on any, the primary tumor, the metastatic site, or a lymph node. And then, let's see, how is BRAF, how is that determined? We kind of talked about that. They have to actually take some of the tumor and tissue from the tumor to look and do molecular profiling. Do you want to just share your slides a little bit as we, and then we can kind of finish up with a couple more questions, Tony, just to talk about some of these new strategies?
Yeah, I'd love to talk a little bit about that. You see my slides pretty good?
We see your desktop.
Oh dear. Let me try that again. Let me see. I've probably got to put it over on this screen. Let me do that.
Recent trial update. Got it.
Yeah, perfect. All right. So we're going to go through these. I'm going to go relatively quickly. We have a lot of data that we could go through, but I want to make this short and sweet and make sure we have time for questions. So I mentioned that we have 2 different kind of drugs. We have immunotherapy and we have targeted therapy. And a question that has been really challenging for us is which one is better first? If you have a BRAF mutation, which is seen in 40% of patients, should those patients get targeted therapy up front, or should they get immunotherapy up front? And then what happens if they progress? And how do we do that? So the DREAMseq trial was recently publicized in November, just this past month, just about 15 days ago. And they looked at which is better. Is it better to give immunotherapy first and then targeted therapy, or targeted therapy first and then immunotherapy? And as you can see in this trial, 40% of patients had a BRAF mutation and have this option of targeted therapy. But according to this report, the survival rate was much higher with immunotherapy combination, followed by targeted therapy. And in fact, when they looked at the patients, the number of patients who were alive with these different approaches, patients who got immunotherapy first had a 72% chance of being alive at 2 years versus those patients who got targeted therapy first, which is 52%. This, we believe, is practice changing. We didn't know the answer to this question in the early part of November. We now have an answer to this question, and it really begs that most patients should be getting immunotherapy upfront, regardless of what their BRAF status is. We have another very exciting trial that was produced or publicized back in June. We're still waiting on the full report to come out, but this is something that's really exciting. There's a new drug out there called a LAG-3 inhibitor. LAG-3, as you can see on this slide, is something called lymphocyte activation gene 3. This inhibits part of the white blood cells, the T cells that we think are so important in fighting off melanoma. And in this trial, they took this drug, a LAG-3 inhibitor called relatlimab. As you can see, I'm struggling even right now with the name, plus nivolumab. And about 350 patients received either the new drug plus Nivo or nivolumab alone. And these patients all had metastatic disease. This was a first-line trial, so all patients were getting their very first therapy. And I want to just mention that this is not a trial that really had a placebo in it. It was a placebo-controlled trial, meaning that the patients who got Nivo actually also got a different drug, which was just a placebo. They didn't know that they were getting Rela. And that's because we didn't know which was better. The Rela could have just ended up causing a lot more toxicity without efficacy. And nivolumab is standard of care here. And so all patients on this trial got standard of care nivolumab. And then 50% of them also got Rela. I will say, as a physician, it's not always good to be on the other arm. We never know which one has better efficacy or more toxicity. And so that's why we do the trials. But in this particular trial, progression-free survival, or how long patients go without any evidence of progression, was about 10 months in the patients who got Rela plus Nivo, and about 5 months, about half of that with Nivo alone. Now, clearly, it looks like the Rela plus Nivo is winning here. This was a large phase 3 trial. It's been put in front of the FDA now, and we really do expect the FDA to see this data as favorable. We expect that the FDA will probably approve this in 2022, probably the early part. And that's going to cause some questions about, well, do we go to this for every patient with metastatic melanoma? Do we still give dual immunotherapy to some of those patients? Even Rela is an immunotherapy in and of itself. So it's going to lead to some interesting questions, but these are all good questions to have because we're just saying that we have more options. So really excited about that. We talked a lot about the possibility of therapy before surgery or neoadjuvant therapy. And I'm just going to outline 2 trials on this slide real quick, something called the Opposite Neo and the Opposite trial. These are immunotherapies in patients with bulky disease or macroscopic disease that we can see on a CT scan or a PET scan, or disease that we can feel on a physical exam, all patients with stage 3. And the design of the trials and how they did things was a little bit complicated. I put a little bit of detail in this slide, but I don't want to spend a lot of time talking about that, but rather look at the pathologic response rate under that first bullet point there, which is 78%. That means that when we take the tumor out after giving therapy before surgery and we take it over to the pathologist, 78% of the time we see that the disease has decreased and possibly, as we saw in that prior patient, gone away completely. So that's really exciting. There was another trial, the Opposite Neo trial, and they saw a pathologic response rate of 77%. So they were basically able to duplicate that finding, suggesting that immunotherapy before surgery could really help decrease the amount of disease that we have. And the preliminary results, and I do have to mention, this is preliminary. These are not large phase 3 trials. That's currently undergoing patient accrual. But the exciting preliminary results are that there's currently a very high relapse-free survival rate. That is, that in patients who have a complete response where there's no disease, at 2 years, 97% of those patients are not only alive, but they don't have a relapse in their cancer. Really exciting data for some of our patients. So I did want to present a case report that's sort of along these lines. I have a gentleman who in 2015 had a chest wall lesion. It was resected. He did have a lymph node biopsy at that time, which was negative, and so he didn't get any other therapy. In 2021, he had recurrence and a new lymph node uptake on a PET scan, and this was under his arm. So now he had disease in his chest wall and his axillary area, and this was all biopsy proven, as we know. He actually did get BRAF testing, and he was BRAF positive. So he's one of those 40% of patients. But we decided after a long discussion at our multidisciplinary tumor board, like we always do, we plan to give neoadjuvant therapy followed by surgery if possible. So this man went on to Ipi-Nivo. He received 3 cycles. He did get an adverse event. And this is something that we have to recognize, is that the therapy that we use is not chemotherapy, but it still has potential side effects. And it's really important to talk to your medical oncologist or encourage those who are receiving these agents to call immediately if there is any side effect, because we can usually stop that side effect from happening and really help the patient. But if we don't know about it, we can't help. This patient appropriately followed up. We were able to stop that surgery, side effect, and we decided to do a PET scan in preparation for surgery. So on this slide, I'm showing the PET scan, and I'm going to walk you through this. We have basically the first PET scan in the first column here, and you can see there's an arm axillary or armpit melanoma that we can see pretty easily here. And then we also see on the chest wall, on the other side of the chest, we see that chest wall lesion. Just to sort of bring you up to date, we're also seeing the lungs here, and we see part of the heart. The heart is metabolically active, and it shows up really well on PET scans, and that's why we can see it. You can see some of the bones, so this is all up in the upper chest here. So this axillary lesion and this chest wall lesion. And the second PET scan that we did after 3 doses, we could not find disease in the armpit. We could not find disease in the chest wall. All the disease had resolved. This patient was another one where he came back and said, "How am I doing?" I felt underneath his arm, and I said, "I don't feel anything." And he said, "Neither do I." And so we knew that something was happening even before we got the PET scan. So this went back to our tumor board discussion. We decided that surgery was probably not really indicated because we weren't exactly sure where to do the surgery anymore. It was going to be difficult to find this and figure out what we were doing. So surgery was canceled, no evidence of disease. He continues on immunotherapy and is doing really, really well. And I just saw him again yesterday, doing great.
I would just echo how excited we are to see responses like this. So I'm going to kind of go through some of the questions as we finish up here, and we can try to get through as many of these as we can. But before that, I just want to highlight for all of you or friends or family, I think it's exceedingly important, especially for advanced melanoma, to be seen by a team like ours that has an expertise and knowledge of treating patients with melanoma. There are a lot more nuances than ever before in how we evaluate and treat patients. Multidisciplinary care is not just talking to a pathologist, or it really is a team approach to cancer, which has been proven over and over again in all different types of cancer to be exceedingly important and improve care. All of us, stay up to date on the guidelines, and I don't know everything, and Dr. Olszanski doesn't know anything. But when we can sit around a table and really discuss, especially really, really complicated scenarios, and we see new scenarios that we haven't seen on a monthly basis, it's really important to have a team approach of experts that can really put their minds together and come up with the best personalized treatment for any patient. And so wherever you live, you want to find a place that has expertise and a center of excellence for melanoma, and taking care and have an understanding of all these types of things. someone had asked about neoadjuvant versus adjuvant therapy. So we generally describe adjuvant therapy is, for instance, after surgical resection, when we've removed all the disease, we then are giving therapy basically to decrease the chance of a cancer coming back, in this setting, melanoma coming back. And so we give it in the adjuvant setting. Generally, for our current adjuvant treatments are generally given for a year currently, as long as it's tolerated for a year. Neoadjuvant is basically giving it before treatment or before surgical approach. So in these cases that we showed you, where the anticipation was for surgery, but we're giving it before that to treat active tumor in place and then going on for further resection. So it's giving prior to surgical resection. So that's neoadjuvant. I'll kind of go through some of these questions. A lot are chemotherapy related. Options for a patient who has a BRAF mutation and a BAP1 mutation, a very rare mutation that we see. Immunotherapy caused ulcerative colitis, and targeted therapy has stopped working. Any other thoughts on? And maybe you can also just give a brief overview of what a clinical trial is and why it's so important.
Yeah, so that's an unfortunate situation, of course, getting immunotherapy and then having a side effect and then having targeted therapy and not working anymore. So the very first part of that question, without knowing obviously all the details, is that's a situation where you probably need a good gastroenterologist and somebody who really knows how to manage these side effects, because occasionally, especially if we think the immunotherapy was working in the first place, we can go back to immunotherapy with the proper precautions and the proper medications to try to control the colitis that happened. And for people who don't know, colitis is an inflammation of the colon. It can cause really quite bad diarrhea. And that can actually be life-threatening. And it is a really big medical issue that can happen with immunotherapy. But that doesn't mean that immunotherapy can't be applied in some of those situations. And recognize that we don't have the answer to everything. We're still learning so much about melanoma, and we're hoping to come up with even better drugs that really don't have a lot of these side effects that we're talking about. To get on to the clinical trial question, all of the agents that we've talked about tonight, all of the new studies that we talked about tonight, the only way they actually come to fruition is through clinical trials. It's really people who have subjected themselves to clinical trials, which means getting good care, getting care that's usually better than standard of care, I'll say, because you have much more follow-up and you're seeing nurses and doctors much more frequently, but allowing their data to be entered into a database so that we can learn more from them, from each patient. And so I want to give kudos out to all the patients, all the thousands of patients who have subjected themselves to clinical trials with hoping that they would be one of the patients that would really benefit from the clinical trial, and knowing that regardless if you benefited or not, you have benefited the community. So greatly appreciative of that effort. So really want to thank you for that.
Great, Tony. Someone asked, are there any new novel ways that you can predict if someone is going to tolerate either targeted therapy? This person did not tolerate targeted therapy and then went on to receive immunotherapy and did quite well.
Yeah, we don't have, that's a really good question. All we have is sort of the frequency of side effects. And so when we talk to patients, we talk to them about side effects. We try to manage side effects by dose reductions or dosing holidays sometimes, especially when it comes to targeted therapies. But we do not have to date any studies that we can do beforehand on a patient's blood work or their genetics that can tell us about tolerability. That's something that we just haven't been able to figure out.
If someone is on immunotherapy, how long do they stay on that? Or if they're BRAF mutated, when would you switch to a BRAF inhibitor? Should you do that? Or do you just stay on one therapy until things, unfortunately, if it progressed, then you switch?
Yeah, obviously, I think if cancer's progressed, then you definitely have to switch. But the idea here is that if you're not progressing, then it's probably doing something. Certainly, if you had a response on immunotherapy, for example, then I would keep that patient on immunotherapy as long as they're tolerating it. And even in the setting of stable disease, where the disease does not seem to be growing, I've had patients where they've had stable disease for a year or two, and then I give them off to Dr. Farma, and he does a resection, and we find out that it's all dead tissue. And so we've stopped therapy in some of those patients. So we do believe that there's a lot of merit in continuing therapy when we think that it's at least causing stable disease or better.
Yeah. What about, and this is a tough question that we talk about, on a weekly basis, patients whose disease has progressed through immunotherapy and then through, if they can get targeted therapy. What is your suggestion in these settings?
Yeah, so obviously we never want to see progressive disease, but we have to realize that the reality is that not everybody who we're going to treat is going to respond appropriately well to immunotherapy. With that said, the current data suggests that almost 60% of patients will have a good response with immunotherapy, but even some of those patients who respond will end up having more disease down the road. And that's where we do look for other alternatives. Clinical trials are a great alternative sometimes for those patients. And if they're BRAF positive, we can also go directly to targeted therapy. And so we will sequence those patients into targeted therapy. I'm taking care of a young gentleman right now who went through immunotherapy. And quite frankly, after 3 doses, it was pretty clear that it was not working. I put him on targeted therapy, and that was 5 years ago, and he's still on targeted therapy. We don't know that there's a real need to get rid of it. He's fortunately tolerating it, and so we're continuing. But this is where the application of clinical trials come, or even other alternatives. I saw in the chat, Jeff, something about TVEC. Do you want to talk about what that drug is?
Sure. So, there's just, in the interest of time, I think there's three really interesting things I just want to talk about briefly in the setting of new novel agents. And we'll talk a little bit, I can talk about injectables. And then we apologize if we can't get to everyone's questions, but through us or AIM, we will provide some answers after the session. So a lot of patients with extremity melanoma will present with nodules that occur, what are in transit, where you get implants in the lymphatic channels where the cells kind of get caught and then grow into nodules. And this can also occur in the head and neck region or anywhere, but we commonly see it in the extremities. There's multiple options for these, including surgical resection, if there's a few of them. We can have intralesional therapy. So we have agents that we can inject into the lesions that we can feel or see, either with ultrasound guidance or just we see the lesions and can inject. And TVEC is a modified herpes vaccine that can be utilized and can cause an immune response and ramp up your immune system to kill the melanoma that you inject, but it also has what's called a bystander effect. So it can actually affect not only what the lesions that you inject, but also your immune system can then affect the other lesions. And so that's an option that we frequently employ in settings where we can have a lesion that we can inject. And we've seen a good success rate with that. I don't personally think it's as good as some of the systemic agents, but in some patients, this is a really good option. Older patients, you do have to come every 2 to 3 weeks for continued injections. And then ideally the lesions go away and we stop injecting because there's nothing more to inject. So that's an option. Another option that I'm one of, a handful of in the country that still does what's called isolated limb infusion, where we actually put an extremity on a bypass circuit in the operating room, and we can give a very high dose of chemotherapy to the limb, which shows still a very good response rate of about an overall response rate of about 60%, a complete response rate of about 30% for patients that have multiple spots in the extremity or that can't be resected or we don't have other options for. So isolated limb infusion is still a viable option. And so as we finish up, I think 2 other questions that I think are really great questions are, What about if you have an NRAS mutation? We do see this very commonly on molecular profiling. What do you foresee on how we'll treat these patients? Are we going to have NRAS inhibitors and the future of kind of another option for patients if they have this unique mutation?
Yeah, NRAS mutations are actually pretty common. They're the second most common mutation that we see in melanoma compared to BRAF mutations, which are targetable. And on the NCCN guidelines, you actually see that there is a drug that we can sometimes use called binimetinib. Binimetinib is actually a inhibitor of another protein called MEK. So it doesn't inhibit RAS directly, but it can be used in some patients. Unfortunately, I would have to say that that data is a little bit challenging. There's a pretty high adverse event rate. A lot of patients can get pretty sick on binimetinib. And also, it doesn't seem to really work very well. Response rates in the less than 20% of patients roughly, and the responses aren't very durable. So this is an active research question. How do we develop drugs that can go after these relatively common mutations more effectively? And the good news is that we're now beginning to learn how to target some of these RAS. We have a different one called KRAS that we see sometimes in diseases like lung cancer and colorectal cancer. And there's now a drug that is approved by the FDA that can go after those specific mutations. So I really think that it's only a matter of time before we find targeted drugs that will target other RASs like the NRAS mutation. I'm really hopeful for that.
Great. And this is the problem that, Sam Guild from AIM had said, oh, you don't have to talk that long, but then we get very excited and we talk about this. So we could probably talk for another 2 hours, but there's two questions that we'll answer and then we'll be done. One is, what is tumor board? And so I can answer that. So we meet either every week or every other week to discuss complicated patients, and different centers do this in different ways. And we do it virtual now. We used to be in a room, but we have all the members of a team: medical students, residents, fellows, pathologists, radiologists, medical oncologists, surgical oncologists, radiation oncologists, head and neck surgeons. So a whole team approach that really sits down. We look at actual slides on the microscope. We look at the imaging and the CAT scans. We will show images like we did today that we may take in clinic, and we sit around and we discuss patients. And so that's tumor board. It allows us to talk about new trials. It allows us to bring up new options. It allows us to discuss if we think someone is eligible for a clinical trial or treatment. And it's really key and important that a lot of these cases are discussed in that. And the last question, because I think I'm really excited about this, and I participated in a lot of the early trials or was involved in when I was at the NIH and the National Cancer Institute. What about TIL therapy? Is that approved? What is it, Tony? And we could probably talk another 2 hours about this, but you have a minute.
Yeah, so Jeff, I have to tell you, and I'll tell everybody that I am so excited about this because it's really the first time that Jeff and I very specifically will be working literally hand in hand. We both need to be part of each other's body in many respects, because TIL therapy is an application where a surgeon like Dr. Farma goes in and takes out viable tumor. And while that tumor is still fresh, it gets sent off to a manufacturing company that pulls out the white blood cells that are in the tumor, called the lymphocytes. So these are called tumor infiltrating lymphocytes. That's where we get the name TIL. And then these cells that are now in a test tube, if you will, are grown up with the melanoma and another medication that we call interleukin-2, so that our hope is that those lymphocytes will learn that the melanoma is the bad guy. And then when we have enough cells that have been produced in this fashion, the patient comes back. We give them something called a conditioning regimen to get them ready for the therapy. And then they come back and they get their own cells. This isn't somebody else's cells. It's their own lymphocytes, their own white blood cells that are now infused back into their body. Remember, these are taught. These are like these are like the Marines, right? These are like the Army. They know what to do. They're going to go hopefully after the target. They do it, and we again apply some interleukin-2. Caveat, interleukin-2 is difficult to get, but we have different ways of being able to apply that now too. And so with TIL therapy, these lymphocytes that are going back into the same patient with interleukin-2, we're beginning to see some really exciting results. And I will say that this research has been decades in development. And we give our hats to Dr. Stephen Rosenberg down at the NIH for really coming up with this. He's a surgeon, started this program decades ago, and it's slowly coming to fruition now as we've really developed in it our advances in making some of these therapies relevant for people.
Great. Well, with that, I think we went even over what we expected, but these were really great questions tonight. I think really it keeps us on our toes, really, on point questions, highlighting a lot of the things that are going on in melanoma. So Sam, I'll hand it back to you. Thank you for inviting us. We really appreciate and love participating in our relationship with AIM at Melanoma. So thank you.
Thank you so much. Honestly, I did not think we were going to go this long, and clearly we could have gone for a lot longer. I told you all out there that there was a lot of stuff too, that exciting stuff that was on the horizon. Some of it's happening this month, some of it right after the first of the year. And so I really appreciate you guys joining us. Thank you, Dr. Olszanski and Dr. Farma. I love working with you guys at Fox Chase, and thank you so for doing this. And Happy New Year, stay safe, and thank you for all that you do for the patients and for the community. I know it's been a difficult couple of years. There's a lot going on, which has made your jobs even harder. And so we really appreciate everything that you're doing. Thank you. Have a great evening, and everybody, happy holidays. Bye.
Thank you.